Rajiv sir, you can proceed, sir.
Very good evening to all. Today we are going to demonstrate clinical examination of foot and ankle live. And in my hospital's auditorium, I am supported by Neerav, his team, Dr. Devansi, Dr. Abhishek, and I have Dr. Neerav, who is going to volunteer as a patient. So friends, when it comes to foot and ankle clinical examination, I say it's a rule of three. Three things examiner does. Examiner examines patient's gait, he examines patient standing, and he examines patient walk. Three examinations he does. He examines foot and ankle per se, he examines the gait of the patient, he examines footwear of the patient. Three things are to be done by the patient. Patient comes walking into the clinic, patient comes with the trousers up above the knee, and patient comes with the footwear and orthopedics on. And then three areas we examine. We examine ankle and hind foot, we examine midfoot, we examine forefoot. And then three things we do in the examination. We do inspection, we do palpation, and we do manipulation. And again, we are going to examine patient in chronology, starting from the ankle, going to the hind foot, going to the midfoot, going to the forefoot. So let's start with the clinical examination of foot and ankle. I am going to request Dr. Neerav to come up as a patient. Neerav, please come in. So look, he is coming walking. He is coming with his footwear on. Can you please sit here? And he is coming with his trousers up because we want to keep it up. We want to see the position of the knee with respect to the knee, the position of the foot and ankle, the lie of the foot and ankle. So that's why we ask patient to come walking with the footwear on, with trousers lifted above the level of the knee. So let's start the clinical examination of foot and ankle. Neerav, can you just remove that, please? Okay. So the first thing for the examination is to make your own chronology, your own checklist or protocol for the examination. Otherwise, you are ought to miss something. So for me, I start with the examination of the ankle and hind foot, then I go to midfoot, then I go to foot. For a right-sided foot and ankle, I will start my examination in clockwise direction. So the first examination would be on the medial side, then it would be on the plantar side, then it would be on a lateral side, then it would be on a dorsal side, and on the posterior side. So medial, plantar, you can zoom out. Medial, plantar, lateral, dorsal, and posterior. If the patient is, if you are examining the left foot of the patient, then you're going anti-clockwise. Again, medial, plantar, lateral, dorsal, and posterior. The first thing you do is the clinical examination in form of inspection of the foot and ankle. So when you inspect patient's foot, you look at the size and shape of the foot, the lie of the foot, the posture of the foot, vis-a-vis the posture of the ankle and leg, posture of the ankle and leg vis-a-vis that of the knee, that of the body. So that is what you look into the inspection. Look for the skin. Are there any scars? Are there any corns, callosity? Always, 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 never forget, look onto the plantar aspect. When patient has got a less frank injury, there would be plantar ecchymosis onto the foot. So you must look at the plantar aspect. On the plantar aspect, when you look, you can look at certain corns and callosities. Corns and callosities, they denominate pressure of bones from top over the plantar skin. And for diabetic patient, if that patient is having corn or callosity, that means there are chances that it might ulcerate because of the pressure of the bone from top. So that's very important. If a patient is a sportsman and he has got a corn or callosity, that is the pressure area and that is going to reduce his performance. So that's why you should be looking at the plantar aspect to be put in the inspection. Look for the presence of varicosities also when you are looking at the skin. And Don't forget to inspect the foot from the medial aspect, plantar aspect, lateral aspect, and more importantly, posterior aspect. So that is what we forget. We forget posterior aspect examination. We forget examination of the plantar aspect. So once you are done with the inspection, the mainstay of the examination is palpation. And there are three palpations: topographic palpation, where you palpate schematically your bone, joint, tendons, ligaments, nerves, everything. And then comes your neurological palpation, and then comes your vascular palpation. So let's start the palpation. By and large, patient is sitting on a table like Dr. Neerav is sitting here, and examiner would sit on a low stool or a table like I am sitting, so that the patient's foot and ankle is lying in the lap of the patient, lap of the doctor. So that is what you require to do. So your topographic palpation starts from the medial side first. Can you just extend rotate it? Okay. So the first palpation and foot and ankle examination is index finger. Index finger of the patient, index finger of the examiner. Ask your patient where it hurts most. He is going to point out with the index finger that this is the area which hurts most. And what you are going as an examiner to do is to palpate with your index finger for the areas of pain, swelling, tenderness, irregularities. That is what you want to see with when you're doing inspection, when you're doing palpation. So I start my topographic palpation by first palpating medial malleolus. So why do I do this? Medial malleolus is seldomly tender in most often than not foot and ankle problem cases. So if your patient winces when you press over the medial malleolus, that means that patient is malignant. And this is very common in the patients who are there for view with a workman compensation issues. So start your palpation with palpation of medial malleolus, and most often than not, it is not tender. If patient winces or patient says it's tender, that means this patient probably is malingering or he has got emotional overlay. Beware while you examine this such patient. So start your examination with the palpation of the medial malleolus, and from there, when you go anteriorly and up, what you palpate is the medial gutter of the ankle. Medial gutter of the ankle would be tender if there is some fibrosis, some impingement, some scarring of the medial gutter of the ankle. From there, if you go more horizontally and more dorsally, you're going to palpate the ankle joint line, which we'll palpate when we come to the dorsal palpation. Okay, in a medial palpation, from the anterior portion, if you go and slide your finger posteriorly, tendon which passes just very immediately just behind the medial malleolus is a tendon of tibialis posterior, which is a very important tendon. And we have learned in our anatomy that the sequence here is Tom, Dick, and nervus hairy. So Tom, that is tibialis posterior. Behind the tibialis posterior, you have a tendon of flexor digitorum longus, Dick. Then you have neurovascular, which I have painted here with a red sketch mark, and then you have a tendon of flexor hallucis longus. So Tom, Dick, and nervus hairy. This is how you remember your palpation. Going down from the medial malleolus, what you palpate all around this area is your deltoid ligament, which is the medial stabilizing structure of the ankle. The first bony prominence which you are able to palpate after medial malleolus on a medial side is a navicular tuberosity, which gives insertion to tibialis posterior. Why palpation of this navicular tuberosity is important? Sometimes patients have an accessory navicular, and these accessory navicular could be the cause of pain. You can palpate. In a flat foot cases, the tibialis posterior tendon is tender, it is edematous, sometimes there is a swelling, sometimes there is a fluid collection that we call tibialis posterior tenosynovitis. So you also palpate the course of tibialis posterior going up from navicular tuberosity. So that is the significance of navicular tuberosity. It comes at the summit of our arch, and when there is a flat foot, the whole navicular sags down when patient stands. Okay. On a medial side, you examine these two bony prominences. You also want to examine sustentaculum tali. So sustentaculum tali is lying exactly halfway and a finger breadth below these two bony prominences. This bony prominence is sustentaculum tali, which gives insertion to a strong capsuloligamentous structure. And below the sustentaculum tali is a tendon of flexor digitorum longus, neurovasculus, and flexor collicis longus. You need to know where is sustentaculum tali whenever you are dealing with your calcaneus fracture fixation, because all your fixation is aimed at sustentaculum tali, which is the strongest portion of the calcaneus. On a medial side, you can palpate your flexor retinaculum and you can palpate for the tenderness of the neurovascular structure. If the tenderness of the neurovascular structure is here, that means this patient has got some kind of pressure by a flexor retinaculum, and the condition which results is called tarsal tunnel syndrome. You all must be aware about it. In the tarsal tunnel syndrome, there is a compression of posterior tibial nerve at the flexor retinaculum or beneath, or once they come out of the flexor retinaculum, and this pressure gives rise to neuritic pain into the foot and ankle and into the plantar foot. This is more so when patient is standing, when patient is wearing a footwear, patient gets relieved while removal of the footwear. Okay, on a medial side, when you go down, a bone which you palpate is calcaneus. Going down from calcaneus, you have something which is called as the soft spot of the heel. So this is the calcaneus, and when you start palpating from the back and come to the front, your finger is palpating a bone, and suddenly there is a give-way feeling, and this give-way feeling is called soft spot of the heel. And all neurovasculars, they enter the heel through this area. So a plantar fasciitis patient, if plantar fasciitis is because of compression of Baxter's nerve or nerve to abductor digiti minimi, this is the area which would be tender, palpable. When you palpate such an area and patient has pain, reproduction of the pain, that means there is neuritic compression, neuritic element of plantar heel pain. So that completes the topographic palpation of the medial side. And from medial side, you go on to examination of the plantar aspect. On the plantar aspect, you have two muscles. One on the medial side is abductor hallucis longus. On the lateral side, you have abductor digiti minimi. And into the center, you have your plantar fascia. And plantar fascia is a strong, tight structure which maintains the arch of the foot. And in a plantar fascia heel pain, which is plantar fascia, the normal way by which you palpate the plantar fascia is to dorsiflex the toes, more so a great toe, and this tightens the plantar fascia, and you can start palpating the plantar fascia medially, and where it ends, this is the medial tubercle of calcaneus. In a heel pain patient, a heel pain because of the plantar fasciitis, this area would be tender. So medial plantar tubercle of the calcaneus is what you are palpating. So, and you are also palpating directly plantar at the heel, and here the region is the region of calcaneal spur. So if patient has got calcaneal spur, right into the center, patient would have tendon. Sometimes heel pain patients, they have a fat pad atrophy. The fat pad of the heel is the biggest and the major most shock absorber of the world. There is no other structure in the world which is more competent to lift the loads like the plantar heel fat pad. So in patients who has got a calcaneus fracture, where there is a trauma, where there is a blood trauma of the plantar flat pad, plantar fat pad might get atrophied. Even as your age advances, your plantar fat pad might get atrophied. So that could be tender. You can palpate it on the plantar aspect. So once you finish the medial aspect, plantar aspect, you go on to the lateral aspect for the evaluation. Can you come from this place, please? Lateral evaluation of the patient. So the first thing here you palpate is your tip of the lateral malleolus. Tip of the lateral malleolus is very, very easily palpable, and then from there you slide your finger up towards the talus. And what you palpate here is a very, very important structure, and this structure is anterior talofibular ligament. This is the ligament which gets most commonly injured into the ankle sprain, and this could give a lot of problems to the patient. So clinically evaluating whether there is synovitis, tenderness, inflammation, pain at this area, which is anterior talofibular ligament, a ligament which runs from the anterior aspect of the fibula, goes to the talus, neck of the talus. This is the talofibular, anterior talofibular ligament. There is another ligament, a part of lateral ligament, which is a calcaneofibular ligament. It's a short, stout, strong ligament. Usually it doesn't get injured. It gets injured. If it gets injured, that means that patient has got a very severe variety of ankle sprain. So just beneath the tip of the fibula, what you are able to palpate is your lateral ligament, calcaneofibular part of your ankle's lateral ligament. Going above and anterior to the fibula, you are going to enter into the lateral gutter of the ankle. And most of the sprain patients, ankle sprain injury cases, they do land up with anterolateral impingement. Some scarring is there into the gutter of the ankle. So that you can palpate. And going further forward, this is the area where you palpate for syndesmotic ligament, tibiofibular ligament. The injury of syndesmotic ligament, this area would be tender, swollen. Going posteriorly from the fibula, tip of the fibula, you have two tendons which are running at the back of the fibula, tendon of peroneus brevis and tendon of peroneus longus. Sometimes these tendons in a rigid flat foot, they would be stout, they would be quite prominent. Some patients, they have post-trauma snapping tendons. So if you ask patient to move the ankle or move ankle in a clockwise direction, patient would be able to dislocate the peroneal tendon, and the peroneal tendon would also come back into the groove. So you can look into that also. From the tip of the fibula, when you go down, there is a bony process. This is peroneal tubercle of the calcaneus, and it is the place where it gives a passage to the peroneus longus tendon. If this tubercle is hypertrophied, then patient might have problems of peroneal tendinitis. Going down and posteriorly, you are able to palpate the flat surface of calcaneus. And then down, you're going to palpate your abductor digiti minimi muscle and the plantar heel fat pad. In the lateral aspect only, you will be able to see the tendoachilles, the anterolateral border of the tendoachilles. This is the area which will get fullness, pain, swelling, tenderness when you have enlarged posterior process of the talus, and this results into posterior impingement of the ankle. So enlarged posterior process talus could be painful, tender somewhere over here, and this is going to give pressure to the tendon of flexor pollicis longus. So this, when you go forward from peroneal tubercle down and anteriorly, you are going to palpate base of fifth metatarsal, which gives insertion to peroneus brevis, while peroneus longus tendon would go through the cuboid canal and is going to insert at the base of the first metatarsal, because it is a plantar flexor of the first metatarsal. So that's your lateral examination. Then you come dorsally, and you come from the top, yeah. So then you go dorsally, and dorsal evaluation, again you start from the medial and come down to the lateral side. The first tendon which you are going to palpate, the first thing you are going to palpate is the medial aspect of the ankle joint. All osteochondral lesions, majority of them, they lie in the medial lobe of the talus. So if you do plantar flexion and if you palpate deep, because you're doing plantar flexion, your talus comes anteriorly and you would be able to palpate the posteriorly located osteochondral lesion. Medial OCDs are very common and most often they're located quite posteriorly. So do the plantar flexion of the foot and palpate this area for tenderness over this area. Going laterally from this area, the first tendon which you are able to palpate is tendon of tibialis anterior. This is then followed by a tendon of great toe, that is extensor hallucis longus. We call it as EHL. Thereafter, you have neurovasculars, anterior tibial neurovascular bundle, and your laterally, when you go laterally, you have a tendon of extensor digitorum longus. Once you palpate extensor digitorum longus, then you come down to the absolute lateral point of the ankle joint. Now, why this palpation is important? Whenever you are doing ankle arthroscopy, your anteromedial portal is just medial to tendon of tibialis anterior. Whenever you are doing your ankle arthroscopy, your anterolateral portal is just lateral to the tendon of extensor digitorum longus. So once you are able to palpate the tendon, then it would be easier for you to place and mark your portal. There is one very, very important nerve which comes in the way whenever we are operating a pilon fracture or we are doing this ankle arthroscopy. And this is a superficial peroneal nerve. In 40 to 50% of the individual, and more so with the thin and lean individual, you would be able to see the nerve, you will be able to palpate the nerve, you will be able to draw the nerve over the foot of the patient. How do you do that? You do plantar flexion and inversion of the ankle and plantar flexion of the fourth toe. The nerve would be prominent and you would be able to palpate the nerve and you will be able to mark the nerve. This is very, very vital if you are doing ankle replacement, if you are doing ankle fracture fixation, if you are doing any ankle surgery, if you are doing ankle arthroscopy, you need to mark this nerve so that you don't damage this nerve. Otherwise, patient would be very, very good with your surgery, but would be very bad with the neuritic pain of damage to the superficial peroneal nerve. So then the last part of the hindfoot topographical palpation is palpation of the posterior aspect of ankle and foot. So Niro, can you just come from the back? So there is no much great palpation. In the center you have tendon of tendoachilles. On both the sides of the calcaneus, if you have a bony bump, that is called Haglund's deformity. So patients who have posterior heel pain, who have enlarged posterior part of the calcaneus would have tenderness over here. There is a bursa which is anterior to the tendon of tendoachilles. That's called retrocalcaneal bursa. So when you have a prominent posterior superior angle of the calcaneus, and when you have a seronegative arthropathy, the retrocalcaneal bursa here could be getting enlarged. And if it gets enlarged, it can give you pain, swelling, tenderness, which is there in front of the tendon and above the level of calcaneus. So palpation of retrocalcaneal bursa, palpation of the Haglund's deformity. And when you see the X-ray, sometimes you find a bony spur at the point where my index finger is there. This is called insertional spur. And tendon of tendoachilles gets inserted over here. And if the tendon also gets degenerated, that is called insertional tendinopathy. So insertional Achilles tendinopathy, when you palpate tendon between your finger and the thumb, the tendon would be tender. So that shows, or it would be nodular, or it would be irregular, it would be thickened, it would be swelled. So this is going to give you idea about the insertional Achilles tendinopathy. So beware of your clinical diagnosis. That's a very important diagnosis. You have Haglund's deformity here, you have insertional spur, you have retrocalcaneal bursa, and you have insertional tendinopathy. So that in fact finishes the hindfoot topographic palpation. And then we'll move to the midfoot topographic palpation, where again you're going from medial to plantar to lateral to dorsal and to posterior. So here, as I say, the most important joint which you palpate is sliding your finger from the ankle over the talus. The first very important joint is talonavicular joint. That is a joint which is a very, very important joint. Any deformity correction in foot and ankle starts with the correction of talonavicular joint. It is the most vital joint to be stabilized. First, if you're doing a triple fusion, triple arthrodesis, then also the first joint which you stabilize and temporarily fix is talonavicular joint. Going from talonavicular joint laterally, there is an area, and this area you see is an area, this is called sinus tarsi. And there is a bulge here, and this soft tissue bulge is extensor hallucis brevis. And somewhere here, over here would be your sinus tarsi, which might get inflamed in many of the patients, which we call sinus tarsi syndrome. So that's about the dorsal palpation. There is no much to palpate on the plantar aspect of the midfoot or on the plantar aspect or the posterior aspect. Nothing else is to be seen. But then comes a very important part of evaluation is your forefoot evaluation. Again, you start from the medial side. On the medial side, look whether there is any prominence of the bone here and any deviation of the hallux. Hallux could deviate into hallux valgus. You could deviate into hallux varus. In India, because we wear a free flip-flop kind of footwear or sleepers, we have tendency of having hallux varus more than the hallux valgus. Hallux valgus, which I am going to talk next week, is quite more common in the Western world because they like to wear high-heeled footwear and a footwear which is very narrow from the front. So there they have, in the Western world, they have more of hallux valgus, and in India we have more of hallux varus. Many of the cases of hallux varus in India are associated with rheumatoid arthritis. So look for the lie of the hallux when you are seeing on the medial aspect. Look for any prominence here. A swelled first metatarsophalangeal joint is an indicator of gout. Gout has most predisposition to this joint. So on a plantar aspect of first metatarsophalangeal joint, look for any con or callosity here. Palpate for the thickness of the skin. Any pressure area is going to give rise to con, callosities onto the plantar aspect of the foot. Now these cons and callosities, they denominate pressure from the top. And there are two varieties of cons and callosity. Sometimes you will see this cons and callosity right over the head of the metatarsals. You can palpate heads of metatarsals, second, first, second, third, fourth, fifth. So if the con or callosities are at the level of the head of the metatarsal, that means that metatarsal is giving more pressure when patient is standing or patient is walking. If the con or callosity is distal to the metatarsal head, that means that metatarsal is little longer and the length of the metatarsal is what giving a problem in form of con and callosity. Okay, so then you come to the dorsal aspect of foot, where you start your examination by palpating your first metatarsophalangeal joint, and on the dorsal palpation, if there is case of hallux rigidus, you have some osteophytes dorsally, and it could end the joint. If it is arthritic, would be tender. Going from first metatarsal phalangeal joint, you palpate second, third, fourth, fifth. Go distally, palpate proximal interphalangeal joint, middle and distal interphalangeal joint. The toes should be observed and manipulated for deformity. And you have various deformity, a hammer toe deformity, a claw toe deformity, or you have a mallet toe deformity. Whenever there is deformity, you try to manipulate the deformity, whether it is corrective or not. And look at the prominence of the tendon here. The second metatarsal might have what we called as avascular necrosis of the head, which is called Freiberg's infarction. And when you palpate second metatarsal phalangeal joint, head of the metatarsal, it could be tender over here. Morton's neuroma would be between second and third and fourth in metatarsals. And when you palpate a wave space with your thumb and index finger dorsoplantarly, and you push it, the Morton's neuroma would be tender. You will be finding tenderness here. You will be finding tenderness here. Not only pressure is going to tenderness, the nerve which you are pressing, and the nerve has two branches. One branch would supply to the inner aspect of the outer toe, another branch would supply to the outer aspect of the inner toe. And there you will have tingling, numbness, and you will be able to elicit this. So that's about the topographic palpation of hindfoot, midfoot, forefoot, where we have gone from medial, plantar, lateral, dorsal, and posterior aspect. Now, the second in the line is the palpation of the nerves. You need to palpate the nerves if you can palpate. And for foot and ankle cases, we give, most often than not, we give foot and ankle blocks. In the block, we try to block saphenous nerve, which is lying over the medial malleolus. We try to block the anterior tibial nerve here. We try to block superficial peroneal nerve here, so that it gives loss of sensation and we can operate the patient. There is one more nerve on the lateral aspect that is halfway between the posterior aspect of the fibula and anterior border of the tendoachilles, and this nerve is a sural nerve which supplies to this area. So for foot, sural nerve supplies to the lateral half of the foot. The tibial nerves branches supply the front of the foot, and you have a posterior tibial nerve together with the posterior tibial vessels, which while going plantarwards divides into a medial plantar and a lateral plantar nerve. And these are the nerves which work for the supply or the sensations of the plantar aspect of the foot. So whenever you are doing a sensory examination, take a cotton wool and look for the sensations, do the vibration sensing also, do the pinprick sensation also, document what is the abnormality into the sensation into various areas, and then compare it with your clinical knowledge of supply of the nerve. So neurological palpation also comprises of palpation of superficial peroneal nerve, which I demonstrated that you're doing inversion, plantarflexion of the ankle and plantarflexion of the fourth toe, and palpating and drawing superficial peroneal nerve. You also palpate the nerve for any tenderness, any swelling, any abnormal swelling is a neuroma of the nerve if it is tender. And when you palpate the nerve, if you strike the nerve, if the nerve has some issue, that nerve can give rise to the neuritic pain, and you document whether it is hyperesthesia or hypoesthesia. So neurological palpation in the foot and ankle is followed by vascular palpation. Obviously, we palpate the anterior tibial artery right halfway at the level of the ankle. We also palpate dorsalis pedis artery. Palpation of the dorsalis pedis artery is done. Ideally, we could go from the top to bottom. I like to go from distal and to come proximal. So first you palpate the first ray, palpate the second ray, and exactly between these two rays, the dorsalis pedis artery goes and enters plantarward. So start palpating from here, and then once you palpate the artery, you can draw the artery over it. If you are operating a Lisfranc's fracture dislocation, it is always advisable to first mark the vessel. Any midfoot surgery you are doing, you have to mark the vessels first so that you cannot injure it during the surgery. So dorsalis pedis artery, and on a medial aspect, to palpate the posterior tibial artery. And so we always do the palpation of these arteries, but we forget the palpation, or we forget the vascular palpation of nail bed. So palpating the nail bed circulation is very important. This is very important when you have done any corrective surgery on a foot and ankle. The first thing which you need to know is the nail bed circulation. Nail bed circulation is important when you are doing a corrective surgery in a rheumatoid arthritis, because there is an element of rheumatoid vasculitis, and so when you do the correction, the toe can get pain. So look at the nail bed circulation. That is equally important for vascular palpation. So vascular palpation is this ends your palpation. Then you're going to go for manipulation. And what you manipulate is you're manipulating joints, you're manipulating the muscles, you're examining the muscles, the individual muscles you are examining, and manipulating joints, looking at the arch of the foot and plantar fascia of the foot. That is what you manipulate. So your manipulation of ankle starts like this. So when you want to examine the ankle's movement, you take in your one hand, you take your heel, and this heel, if it is into the valgus or varus, is first brought into the neutral position. That is very important. And patient's foot is resting over the forearm of the examiner. And then you are checking the active dorsiflexion and plantar flexion happening at the ankle. But look at the way I have taken the heel in my hand and I have corrected the heel into the neutral position, and then I am checking the dorsiflexion and plantar flexion at the ankle joint. So when you want to check the movement at the subtalar joint, your one hand is into the lateral gutter, your thumb is into the lateral gutter, your thumb is into the lateral gutter, and your index finger is into the medial gutter. So you are palpating talus. And the same way, you are holding the heel of the patient in one hand, and the foot is resting onto the volar aspect of the forearm of the examiner, and you manipulate the joint into inversion and eversion. While you are doing that, your head, your finger and thumb is over the talus. So you are documenting whether the movements are occurring at talus or movements are occurring below the talus. So that is the subtalar joint movement, inversion and eversion. The another important movement is at transverse tarsal joint. Transverse tarsal joints, they do not have much movement. They have abduction, adduction movement, a very slight movement. So you start following the talus, and that there comes your talonavicular joint. So put one thumb of yours onto talonavicular joint, hold the heel into neutral position, and then manipulate foot with your hand over the talus head. You manipulate foot into abduction and adduction and palpate whether the movements are occurring at talonavicular joint or not. So these three are the very vital movement evaluation in foot and ankle. And then you have to evaluate the movement of the metatarsophalangeal joint and individual small joints of the toe. So the most important would be this movement. You also manipulate the arch. Look at the arch. The clinical evaluation of the arch is done best into the standing position. You just have look at the shape of the foot, whether it is a high arch foot or a low arch foot. High arch foot is called cavus foot, and low arch foot is called flat foot. If the flat foot is there, the heel is going to go into valgus, outward drifting of the heel. For a cavus foot, where you have a very high arch, the heel is going to go into medial deviation. So that is a cavus. Cavus has varus, flat planus has valgus. That is what you must remember. Okay. So manipulation is in this form of examination of doing the movements and then movements of the joint. And you now examine individual muscles. The most important evaluation is clinical evaluation of efficacy of tibialis posterior tendon. So how do you do that? You ask the patient to put the foot over the opposite lower end of the knee or thigh or over the knee. And then If you want to evaluate you put the foot, so you manipulate foot into the plantar flexor and then ask patient to inward the foot and give a pressure. This is what is going to give you correct evaluation of isolated tibialis posterior tendon strength. So this is what you do for tibialis posterior. For tibialis anterior, the foot is taken into dorsiflexor and you ask patient to do inversion. Lift it please and palpate over the tibialis anterior. So this is how you evaluate tibialis anterior and tibialis posterior. When you want to evaluate peroneal, you ask the patient to invert the foot and give pressure and palpate at the back of the fibula. This is how you palpate for the peroneal. Obviously, dorsiflexion of the great toe, you can ask patient and look the resistance which you get while you are not allowing patient to do dorsiflexion. Thereby, you test extensor pollicis longus. For testing extensor digitorum longus, your 4 fingers are put over the toes. You ask patient to dorsiflex the toes. Pull your toes up and look the way he is giving resistance to you. So that's about, and again, you want to examine flexor pollicis longus, ask patient to plantar flex the great toe and give resistance and palpate the power. You can similarly do that for flexor digitorum longus for the lateral pole toes. Evaluation of the power of tendo-Achilles is very, very important. So for that, you must ask patient to bend the knee. So flexion of the knee would obviate extra strength. So just flex it and then you can ask patient to plantar flex it and give resistance. You palpate tendo-Achilles. How is the power of tendo-Achilles and patient is doing that. So that is about the manipulation. Now we have evaluated this patient into the sitting position, but the next important examination would be standing examination. So could you stand without the footwear, please? In the standing examination, you look for the size and shape of the foot. You look for the position of the foot with respect to position of the leg, position of the foot and leg with respect to position of the knee, whether there is in-toeing, out-toeing, and when you are trying to evaluate the deformity, the standing evaluation you will be doing from ankle and you're going to look into 3 planes: coronal plane, transverse plane, and sagittal plane, and document your deformity in that manner: coronal plane deformity, sagittal plane deformity, axial plane deformity, hind foot, mid foot, and foot. And whenever you are asking your patient to stand, as an examiner, you should be moving all around the patient, starting from the front, go to the lateral side, and most importantly, go to the back of the patient and see whether the heel is lying into the neutral position or heel is into valgus, heel is into var. And when you look onto the medial aspects, look at the arch of the foot medial. And the last part is examination of the gait. I think gait examination is in itself a big topic, but what you're looking when patient is coming to you and you're looking at the gait, you're looking at the stride, the length of the step this patient is taking. You're looking at the gait cycle, whether patient is doing heel stride, flat foot, and toe off. Is there any limp? Is there any wincing? Is there any pain while patient is standing or walking? Is what you want to see. You want to see the position of the foot and ankle, vis-a-vis knee, vis-a-vis hip, vis-a-vis back, whether he is leaning on one side or on the other side. So, and you are also wanting to see the posture of the foot while the patient is walking. Is he having pain or not? And then some very important foot and ankle gaits. I'm going to just demonstrate here. Put it as it. So can you focus on my lower leg and the lower part of the body? So Antalgic gait is a gait where patient has got lot of pain. So whenever patient walks with an antalgic gait, the step he puts in, he gets in pain. So he's going to lift the other limb very quickly, and his steps would be short and his gait would be little quicker. So he is going to avoid to put weight for a longer time on a painful foot. So that is the antalgic gait for a patient. So his stride length is small. He stands less time. He spends less time into the stand space, more time into the spin. The another important gait is a drop foot gait. The patient has got paralysis of the dorsiflexus. He is not able to clear the ground, so he is taking use of the knee for clearing the ground. So this is what is going to go with use of the knee, and his foot is going to put flat because he has a drop foot gait. So these two are very important gait for foot and ankle problem. So after evaluation of the gait, the next important evaluation is the evaluation of the footwear and the orthotics or the footwear correction which this patient is wearing. So what do you do in the footwear examination? You look at the shape of the foot. You look at the shape of the footwear and compare it with the shape of the foot, whether it is matching the shape of the foot or not. And then you look at the creases onto the footwear. If the footwear has got a lot of creases, that means this footwear is not good and this footwear can give injuries to the patient. Normally, when we walk, we have a crease into our shoe at the level of junction of forefoot and midfoot. But if the patient has got more number of creases in the footwear, that means that footwear is a very risky footwear. Patient can have injury to the foot. Look at the heel counter, whether there is any wear, and look also on the plantar aspect, whether there is any wear or tear of the footwear or not. And then there are some special tests which you are doing for the footwear evaluation. And one such test is called flexing test. So take a footwear and try to flex it. Normally this footwear will flex at the junction of forefoot and midfoot. If it flexes too much at the other areas, that means, so let me take a chance to thank Dr. Devanshi for being with us in this. Thank you, Dr. Devanshi. Okay, so in a flexion test, what you do is you flex the footwear at the junction of forefoot and midfoot. Normally, footwear should flex at this level. If it flexes at multiple levels, that means this is a bad footwear that requires to be changed. Otherwise, patient or a sportsman is going to get injured. The another test is a torsion test. So hold the footwear from the back and twist the footwear. If this footwear twists a lot, that means it's a lax footwear, then it is going to be injured. So my footwear is twisting a lot, and if I ought to play sports with this kind of a footwear, I am going to be getting injured. So there are more chances of injury. So that's the footwear examination in foot and ankle. And the last important part of my presentation, my demonstration, would be demonstrating certain special tests which you are doing for foot and ankle examination. So the first special test which we do is called Thompson's test. Anybody can tell me that for what Thompson test is meant? Anybody from the participants?
Yes, anybody who wants to answer, you can unmute yourself and give answer. Please take part in interaction.
For tendo-Achilles rupture.
Do we have any volunteer?
Yes, speak again. Whoever gave answer, speak again.
Tendo-Achilles tendon.
Tendo-Achilles rupture.
Yes. Sir, they are saying that tendo-Achilles rupture.
Absolutely, perfect. Great. Okay, so I'm going to ask Dr. Nirav to lie on his tummy for a minute and flex his knees. And I'm going to compress the calf at the middle of the calf. So if I compress the calf and foot goes into the plantar flexion, that means the tendo-Achilles integrity is there. So this is how you test the Thompson's test. Now always compare it with the opposite side. So when you press the calf, patient would have plantar flexion if the tendo-Achilles is not ruptured. Thank you. So the second important test I'm going to demonstrate is for the syndesmotic injury. So for syndesmosis, there is one test which is called a squeeze test. So when you squeeze the upper part of the calf, where your tibia and fibula are squeezed between two palms, you will have reproduction of the pain at the level of the syndesmosis. That is a syndesmotic, that is called calf compression test for syndesmosis. But this test is not so sensitive, not so specific. But the important test which we do for knowing the integrity of syndesmosis is an external rotation test. So you are holding the calf with one hand and with the other hand, you are taking in your hand and you are externally rotating the foot. And if this external rotation of the foot produces pain at the level of syndesmosis, it is the surest sign that this patient has got syndesmotic injury. There is another test which is called cross-leg test for the syndesmotic injury, where you are asking patient to put the ankle, lower third of the leg over the knee, and ankle is hanging, and this when gives an external rotation, patient would have pain at the level of the syndesmosis. So this is the third test for syndesmotic integrity. The most important test for any foot and ankle surgery for any chronic problem is silver scoid test. And this is a test where you want to know whether there is contracture of the tendo-Achilles or not. And if the contracture of tendo-Achilles is there, is it the one which is because of the contracture of the tendon of soleus as well as gastrocnemius, or you only have the contracture of the gastrocnemius? So you ask patient to put legs flat over the table, and then ask patient to do dorsiflexion and compare dorsiflexion with the opposite side, and you know the range of the dorsiflexion. You compare dorsiflexion with the opposite side, look whether there is a restriction of dorsiflexion or not. Once you look for that, you have to correct the heel which is into varus or valgus and look for the dorsiflexion like this, and then this is into the neutral position of the knee or extension of the knee, and then you gradually flex the knee and look whether the dorsiflexion improves or not. So if patient has no improvement into the restricted dorsiflexion in extension of the knee and flexion of the knee, that means there is contracture of tendo-Achilles. But if the patient has got restriction of dorsiflexion of the ankle, which increases, the range increases on flexion, that means the gastrocnemius contracture was there. It was the gastrocnemius which spans knee, right, up to the leg, which was tight, and because of the knee flexion, gastrocnemius got relaxed, and there was increase in the dorsiflexion. So that is a test for the tendo-Achilles contraction. You do a calcaneal compression test to diagnose the stress fracture of the calcaneus. For that, you're putting your both the hands, fingers on the plantar aspect, and your flat of palm is over the lateral and medial aspect of the calcaneus, and you are pressing it. Any stress fracture of the calcaneus, patient would have pain and tenderness here. The another test is for a tarsal tunnel test. Like you have a brachial stress test, you have a tarsal tunnel stretch test. It's a very sensitive test. So what you are going to do in this test, you want to put in maximum stretch into the tarsal tunnel and look whether patient has got reproduction of the symptoms or not. So extension at the knee, full dorsiflexion at ankle, and then you are manipulating the ankle, can you keep it close, into the eversion and dorsiflexing all the toes. So you have put in maximum stretch onto the tarsal tunnel, and if patient has pain at the level of the tarsal tunnel with neuritic symptoms, that means this patient has got compression at the tarsal tunnel syndrome. So extension of the knee, dorsiflexion of the ankle, eversion of the ankle, dorsiflexion of all the toes, and stretch your tarsal tunnel and look whether patient has got tarsal tunnel stretch test positive or not. There are some other important tests. A test called modulus click, where you are pushing the metatarsals together and also manipulating the metatarsal in dorsiflexion and plantar flexion. If there is a Morton's neuroma, a neuroma would slide between the two metatarsals and there would be a click, which is called as Mulder's click. And if the patient has got Morton's neuroma, this compression is also going to reproduce the symptoms of pain and paresthesia. Now, there is a test which is called Latchman's test for the small joints of the foot and ankle. So you hold proximal aspect of the proximal bone to that joint, and then you hold the distal toe, and if I am going to lift the proximal phalanx dorsally and plantarly, I am going to look for a pain or excessive mobility, stiffness or instability, and I'm going to compare it with the opposite side. So whenever you want to do Latchman test, it is for the instability of the small joints of foot and ankle, and for that you need to hold proximal bone and you need to hold distal part of the toe, and then you need to manipulate it into the dorsiflexion and plantar flexion to know the instability of the joint. Two important tests for the lateral ligament injury is an anterior drawer test and a lateral stress test. So for an anterior drawer test, patient is hanging the leg and your foot is lying into the plantar flexion. You are holding the heel into one hand and your tibia is held by other hand, and you try to push either tibia back or foot. And this is into the 20 flexion. So hanging limb, relax at the knee, plantar flex foot, and then you are trying to push either talus, trying to push tibia back and talus to the front and foot to the front, or the reverse. And look whether there is any dimple production, whether there is a suction production at the level of ankle, whether it is moving more than the opposite side. Always compare it with the opposite. This is the anterior drawer test for the ankle. And the another test is lateral stress test to know the integrity of the lateral ligaments of ankle. Again, you are holding the heel with one hand, plantar flexion of the foot, and then you are stressing the ankle laterally. And look, we feel that this ankle is quite lax, but you need to compare it with the opposite side, and then only you will be able to differentiate, yes, whether there is any lateral ligament injury of the ankle and ankle has got lateral instability or not. So that is instability test for ankle. Now we are going to have two tests which are very vital to diagnose the flat foot, and then one test which would diagnose the cavus foot. So can we ask Dr. Neerav to come to the wall? Just stand with your both the hands. So first explain the patient this and what you are going to do. So explain the patient that I want you to stand near the wall with some support taken over the wall, not that full support, but two hands are lying on the wall, and then you show the patient that what you want. And can you come from the back, focus over my foot. So you explain the patient that you want him to lift one foot, and you show the patient that you want him or her to rise over the toes for 6 to 7 times and come back. So normally when you rise over the toe, the heel goes into varus, So you look for the movement of the heel, whether heel is going into varus or heel is not going into any heel state, and whether patient is able to do this single heel raise test for 6 times consecutively with one leg. If patient is going to do that and patient is going to do that perfectly without pain, that means his tibialis posterior is intact. He is not having injury of the tibialis posterior. But if patient is not able to do that, that means there is a injury of the tibialis posterior tendon. So, Dr. Miro, can you just do single heel raise test for us? So, yeah. So I've asked him to lift the one limb and he's trying to raise himself 6 times. Please, go on. Look at the movement of the heel, whether heel goes into varus or not, and whether he is having any pain or is not able to do that or not. So that is single heel raise test for knowing the integrity of tibialis posterior in a flat foot case. And can you just stand with the front facing to the wall? So there is another test which is called too many toes sign. So normally when we go to the back, we are able to see only one toe, only little toe and part of the fourth toe would be seen. If you have a patient where you are able to see so many toes, that means that patient has got his heel into valgus and forefoot into abducted position. So that is called too many toes sign positive. You need to just come. I'm just going to show you that how the too many toes sign look like. So for too many toes sign, when patient has got valgus, you will be able to see more number of toes when you stand and examine patient from the back. And the last important test is called as Coleman's block test. So Coleman's block test is a test where you want to know that in a cavus foot, the varus which is there is forefoot driven varus or it is a hind foot driven varus. So for that, what you do is you ask your patient to put the foot onto a board or a book which I put, and ask patient to drop the medial ray from this book and then go to the back of the patient and see whether the heel which was into varus got corrected. If the heel got corrected, that means this varus is driven by the hind foot. If heel remains into the valgus, that means this varus is because of the forefoot. And then you need to do forefoot procedures to correct that cavus. If that is because of the valgus, varus due to heel or the hind foot driven varus, then you need to do hind foot. So by and large, this finishes the clinical examination of ankle and foot. Any questions you have, I would be very happy to answer the questions. Yeah. Do we have some questions?
Yes, thank you very much, sir. Any resident who wants to ask question, please proceed. Sir, there was one question that while checking movements of the ankle joint, what would be the position of knee joint? Is it should be in extension or 90-degree flexion?
Could you just repeat the question? Examining the ankle joint.
Yes, sir.
If I understand, that is the question.
Yes, sir.
While you are examining the ankle joint, knee has to be relaxed. And so for relaxation of the knee, the 90-degree of the flexion of the knee with patient sitting and knee relaxed is the best position for you to examine the ankle.
Okay, sir. Okay, sir. Any resident wants to ask question?
Srikunj.
Yes, sir.
Rajeev.
Please.
This is Dr. Bashore.
Sir, good evening, sir.
There are one or two small things. Regarding when you patient stands on the toe and you are behind, the heel normally goes into RS. Those who are rigid flat feet, that is the test which you used to do. It's a Roseweller test or something. That the valgus does not get corrected. That means this is a very this is called rigid flat feet. Is this test still done or no?
It is 2B or stage 3 flat foot. Normally, flat foot is classified as stage 1, which is a correct. Where it is deformities is not correctable, and then stage 3 is a stage of arthritis with a fixed deformity, and stage 4 is where there is involvement of the ankle over and above the foot. So as sir said rightly, that when you go to the back of the patient and you ask patient to rise on the tiptoe, if the heel remains fixed into the valgus, that means that patient has got a bad flat.
The second test, we used to make them stand with completely on the weight bearing, and you flex the great toe. If the arch forms, that means it's a mobile arch, fairly mobile arch. And if the arch does not form, is this test still valid or no?
Yeah. So this is so when you do the extension of the great toe, you are making arch tight. So that is where a windlass mechanism of the plantar fascia comes into action. So if you raise the great toe and if arch recreates, that means your arch is good, it is flexible. If it doesn't, that means the arm. That test is also there. That's mainly used for the pediatric patients.
Yeah. We used to do this. Secondly, for completion, I know you have done a greatest, fantastic job. I learned quite a bit of things. Especially once the foot comes into the problematic, so I think they need to examine if there is a hyperlaxity. They need to examine the other part. And second, other important is if you are looking for a Charcot or something, they got to put a hand or see the spine also with these patients.
The another important thing is that in today's world, all the foot and ankle problems are assessed with the weight-bearing X-rays. Nowhere in the world for foot and ankle non-weight-bearing X-rays comes. So non-weight-bearing X-rays is given a way to weight-bearing X-rays. Because majority of the problems we face are while we are weight-bearing. So you need to have all your X-rays into the standing position. So standing position X-rays are most vital for foot and ankle problems. That's how the arch drops and how your deformity is going ahead when patient stands. So that's why every X-ray we take is weight-bearing X-ray. Weight-bearing X-ray of the AP and oblique of the ankle, lateral of the ankle, AP and oblique of the foot in a weight-bearing position.
And Rajiv sir, what are the usual important measurements in a foot and ankle case? One student has asked in message, what are the important measurements?
These important measurements are radiological measurements, and this radiological measurement is on a standing X-ray. The most important one is Mary's angle or Mary's line. So you want to see in a lateral as well as in an AP X-ray of the foot a mid-axis of the first metatarsal, and mid-axis of the talus should not make any angle. It's a straight line. If that makes an angle, that means that patient has got dropping of the arch and that patient has got flat foot. So that is onto the AP X-ray as well as onto the lateral. You also see on an AP X-ray the coverage of the head of the talus by the navicular. Normally navicular completely covers the head of the talus, but in a flat foot, the head of the talus goes medial and plantarwards, and so the whole of the head of the talus would be uncovered by the navicular. So there is a measurement called uncoverage of head of the talus by navicular, which you see onto the AP X-ray. In flat foot, you also look at the height or the pitch of the talus, pitch of the calcaneus, whether calcaneus is dropped or not. In a fracture cases, you document what is called as talar declination angle. So in a calcaneus fracture, if the fracture has got quite a bit of compression and shortening, the talus, instead of lying 120 degree with the tibia, would lie into 90 degree or more dorsiflexion when patient stands in a standing axis. This is called talar declination angle. So if this talar declination angle is reduced, then patient has to be treated with a distraction subtalar joint fusion. So that is talar declination angle. The another important measurement is for the hallux valgus, which we are going to talk sometime in the next week. So that there you have a hallux valgus angle, you have a distal metatarsal angle, and you have a intermetatarsal angle for the hallux valgus. And all of them are weight bearing. So we'll discuss that when we are discussing the hallux valgus.
Okay, Rajeev sir.
There is one important view which is called hindfoot alignment view. So that is the view which is also called as Salzmann's view, after the name of the orthopedic foot and ankle surgeon who documented and demonstrated this view. It is the standing view of tibia, talus, and calcaneus. And that is the view which is taken from the back, and patient is standing over the cassette, and you take the view from the back and you see the alignment of the heel with the talus, with the tibia, and that's an excellent view for you to document the deformity and plan your correction for the deformity. Please, you had some questions, go ahead.
Sir, any significant measurements clinically, like vertical height of heel?
The clinically the most important measurement would be your dropping high arch or it's a low arch. That is what you want to see. And clinically you want to document to see the deviation of the foot into adduction or abduction. And you see the deviation of the heel into varus. So that is
Okay, any other question?
anything else?
Sir, can you explain once silver scale test taken, sir?
Which test?
Silver scale test.
Okay, Rajeev sir, can you explain a silver scale test, sir, again?
Okay. So you want me to demonstrate it again, or you want me to just explain it?
Just explanation is enough, sir.
So the gastrocnemius takes origin from the plantar medial and lateral femoral condyles. So it is the muscle which is spanning the knee and the ankle. So you want to document whether this tendoachilles tightness with this loss of dorsiflexion of the ankle is driven by gastrocnemius tightness or is driven by gastrocnemius plus soleus tightness. So when you try to do dorsiflexion with the knee straight, both the muscles, they come into action, gastrocnemius as well as soleus. But the same dorsiflexion, when you flex the knee to 90 degree, would increase or would improve if the gastrocnemius is the one which is giving tightness. So in that case, when you flex the gastrocnemius, when you relax the gastrocnemius, the dorsiflexion would improve. So this test essentially tries and documents whether the restriction of the dorsiflexion or is driven by gastrocnemius or is driven by gastrocnemius plus soleus both. If it is driven by gastrocnemius and soleus, there won't be any change into the dorsiflexion when you test the dorsiflexion in extension and when you test the dorsiflexion in flexion. But if it is because of the gastrocnemius tightness, when you flex the knee, dorsiflexion would improve. I think it's clear now.
Thank you, sir.
Yes, sir. And Rajeev sir, thank you very much, sir. The lecture was in very great detail. You cleared each and everything about ankle and foot examination. Thank you very much, sir, for your time and efforts. Thank you very much, sir.
Rajiv, thanks.
Thank you.
Thanks.
Thank you very much,
Thank you, sir.
Pachore sir, who has always been a fatherly figure to me, and I have always respected him. Sir may forget, but there was a patient, a lawyer from Baroda, who was operated 3 times for the hip replacement. 3 hip replacements were failed, and then he was sent to by me, and you made him up and above. So I enjoy my relationship with Pachore sir from long years, and I'm truly obliged by his kind invitation to come and speak in front of this August upcoming young orthopedic surgeon. So thank you very much for providing me with this opportunity, and I would wish everybody a healthy and safe life. Thank you very much, and
Thanks.
very good evening.
Thank you.
Yes. Thank you very much, sir. Thank you very much, and have a good day and a good night, sir. Thank you, Rajiv sir. Thank you, Pachore sir.
Thanks.
Yeah. Yes.
Thank you. Bye bye.